Dear students, in this video, I'm going to talk about the two different heart failures and their implications in the ICU with regard to the management. So, this is the heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction. Let us go through these cases. The first case is a 72-year-old hypertensive diabetic woman who presents with progressive dyspnea of New York Heart Association grade 3, along with orthopnea, pedaledema. The blood pressure is 164 by 92. Heart rate is 88 per minute, irregularly irregular. BMI is 31. On chest auscultation, there are basal creps. S4 is present. In ECG, there is AF. The echocardiography shows ejection fraction of around 60%. There is concentric LVH, diastolic dysfunction grade 2, along with LA enlargement. There is another case, a 58-year-old male chronic smoker who is post-MI 3 years ago and who has presented with fatigue, dyspnea on exertion grade 3, orthopnea, cool extremities, low volume pulse. The blood pressure is 92 by 60, heart rate is 104. The chest showing diffuse crackles along with S3 gallop. ECG shows Q waves in the anterior lid, and echocardiography shows an ejection fraction of approximately 30%, along with global hypokinesia and dilated LV. Now, both the patients are presenting with heart failure, with features of heart failure, but the ominous signs are different. And how do we interpret this difference? Now, whenever there is a normal heart and there is heart failure, this heart failure progression from a normal heart to a failure state can be accompanied with an ejection fraction which is either reduced or which is preserved. When the ejection fraction is reduced, we call it heart failure with reduced ejection fraction. When it is preserved, we call it heart failure with preserved ejection fraction. Now, when we look into the pathology, we find that in heart failure with reduced ejection fraction, there is enlarged left ventricle, reduced pumping ability with thin walls and weakened muscles. On the contrary, whenever we have heart failure with preserved ejection fraction, we find normal or small left ventricle size with thickened walls, stiff muscle, normal pumping capacity, but with high pressures being required to fill the ventricle. So this contrasting both these can present with heart failure, and the management is slightly different. That is why both ECCF and EHH has jointly classified the heart failures into four types. One, where, as I said, the ejection fraction is less than 40%. It is called the heart failure with reduced EF, also referred as systolic heart failure. And it is seen that there are some therapies, efficacious therapies, which have been demonstrated in some of the RCTs in heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction is defined when the ejection fraction is more than 50%, and it is also referred as diastolic heart failure because here the problem is with the diastolic function, in contrary to systolic function in heart failure with reduced ejection fraction. So, in heart failure with preserved ejection fraction, several different criteria have been used to further define this heart failure with preserved ejection fraction, which is in short also called as HEFPEF. The diagnosis is challenging because it is largely one of exclusion after excluding potential non-cardiac causes of symptoms suggestive of heart failure. And efficacious therapies have still not been identified, although they have been identified to some extent, but it is not as foolproof like the heart failure with reduced ejection fraction. Other than these two, the classification also takes two other heart failures. One is heart failure with preserved ejection fraction borderline. that is where the ejection fraction is between 42 to 49%. And these patients fall into borderline or intermediate group because their characteristics, treatment pattern, and outcomes appear similar to those of patients with HFpEF. There is one more category, which is called HFpEF improved, which has been recognized that a subset of patients with HFpEF previously had reduced ejection fraction. Later on, they become preserved ejection fraction. These patients with improvement or recovery in ejection fraction may be clinically distinct from those with persistently preserved or persistently reduced ejection fraction. And research is ongoing to better characterize this group of patients. So these are the four heart failure with regard to the ejection fraction definitions of HFpEF and HFrEF as given by ACCF and AHA. So if we go back to our case, the first case, who is a 72-year-old female, obese, long-standing hypertensive with S4 sound, echo is normal, but there is left ventricular hypertrophy. So despite normal ejection fraction, she has symptoms and signs of heart failure, strongly suggestive of HFpEF, where the key driver is impaired relaxation and increased left ventricular stiffness. And this is what is leading to elevated filling pressures. In contrast, if we go back to our second patient, who is a 58-year-old, 3-year-old MI patient, who is in whom S3 sound is heard, ejection fraction is 30% with dilated LV. In this patient, low ejection fraction plus dilated ventricle clearly indicates that this is heart failure with reduced ejection fraction, likely as ischemic cardiomyopathy. So there has been a lot of trials on HFpEF as per the pharmacological treatment is concerned, starting from the beginning of this century. And some of these trials did not come to any definite conclusion or didn't show any positive results, but they have been conducted across a lot of pharmacological therapies, which includes mineralocorticoid receptor antagonist, cyclic GMP stimulators, angiotensin receptor blockers, ivabradine, digoxin, then sodium glucose cotransporter 2 inhibitors, GLI receptor antagonist, angiotensin neprilysin inhibition antagonist, angiotensin converting enzyme inhibitors, phosphodiesterase, that is PDE5, PDE5 inhibitors, etc. So as time has progressed, we have found that those earlier trials have been largely replaced. As you can see that in around 2020 onwards, we get only one or two trials. After 2020, we did not find any trial with cyclic GMP stimulators because the previous trials were also not very positive about it. But what we find that glucagon-like peptide receptor antagonist, then mineralocorticoid receptor antagonist, so and sodium glucose cotransporter 2 inhibitors. So these are the trials which have been conducted largely. If we look into the major positive trials, that includes the DELIVER, where the agent is dapagliflozin, the EMPEROR or the preserved ejection fraction, where the empagliflozin, the POOLED, the PARAGON, and the PARAGLIDE heart failure using sacubitril valsartan, the STEP HFpEF using semaglutide, the STEP HFpEF DM also using semaglutide, the Fine Arts heart failure using finerenone, and the Summit using tirzepatide. So there has been a trend towards these substances, which because of the positive trials. There has also been observance of adverse events in major HFpEF clinical trials, like in DELIVER trial where dapagliflozin was used. It was found that there was a little bit of renal adverse events, but this was comparable to the placebo. In other trials, there were some differences, like in the POOLED PARAGON heart failure and the PARAGLIDE heart failure with sacubitril valsartan versus valsartan. We can see that the serious adverse events like hypotension was higher in the paragon as against paraglide. So these are also some of the things that the renal adverse events was higher with was lower with semaglutide, but was also found to be higher than semaglutide when Finridon was used. So therefore, there has been observance of some of the adverse events, although it cannot be said with confidence that all those adverse events are clinically significant as to stop the trial, because none of this trial had to be stopped prematurely. So when we look into the HFpEF treatment, we find that this SGL2I, that is sodium glucose co-transport inhibitors, and Finrenon are probably being used in all patients based upon the evidences. The loop diuretics only in patients with fluid overload. The ARNI in patients where the ejection fraction is between 50 to 57%. The GLPI receptor antagonists in obese patients. And regardless of the phenotype and the clinical settings, for all HFpEF patients lacking other contraindications, SGL2 inhibitors and non-steroidal mineralocorticoid antagonist Finrenon are considered as the first line therapy. So whenever we approach our patient, our goal has to be met by the treatment chosen. So in order to reduce congestion in HFpEF, the strategy is to give diuretics, but we should be careful to avoid underfilling. To improve the diastolic filling, we have to control the BP, and BP can be controlled using either ACE inhibitors or angiotensin receptor blockers or neprilysin inhibitor. And heart rate control in AF can be achieved either with beta blocker or diltiazem. To reverse the comorbidities like weight loss, sleep apnea fragment, glycemic control, so in those cases, SGL2 inhibitors, both empagliflozin and dapagliflozin have been used. The prognostic therapy has also been found to be influenced by these drugs, like mortality and hospitalization reduction. And exercise rehab has been found to improve functional capacity significantly. So these patients need to be inducted in some types of exercise rehabilitation programs so that they can improve fast. So most large trials, however, did not demonstrate significant mortality reductions. There was some, but not significant, while providing efficacy in heart failure hospitalization. Now, more than mortality, there were benefits with regard to hospitalization. That is, the newer drugs needed less frequent hospitalization because of heart failure. So if you see a patient with symptomatically, in contrast to heart failure, preserved ejection fraction, in reduced ejection fraction, the situation is different, because here the congestion is there, so we have to use diuretics. If the patient is started on ACE inhibitors and beta blocker, and they are titrated to maximum dose, and if they're still symptomatic, then here also it is good to add a mineralocorticoid receptor antagonist, Finrenon, and uptitrate to maximum tolerated evidence-based dose. So these are in green, what you can see, these are all class 1 evidences. So if after adding mineralocorticoid receptor antagonist, they're still asymptomatic and they're still symptomatic and the ejection fraction is less than 35%, but then we will have to choose the other paths. That is, if they're able to tolerate ACE inhibitors or ARBs, then ARNI is to replace the ACE inhibitors. If the sinus rhythm QRS duration is more than 130 milliseconds, it is important to evaluate for the need for synchronization therapy, cardiac resynchronization therapy, or CRT. If the patient is having sinus rhythm but heart rate is more than 70, one has to consider for ivabradine. So both ivabradine and CRT are class 2A evidences, but all others are class 1 evidence. And if there are resistant symptoms, we have to consider digoxin or LVAD or heart transplant, although no further action is required if you consider reducing the diuretic dose otherwise, if the resistant symptoms are absent. So as you can see that heart failure with reduced ejection fraction management is mainly towards ensuring that the cardiac output, somehow we are able to improve the contractility of the heart without occurrence of any adverse effects, only to ensure that the ejection fraction improves further. So there is a series on which whether we use ARNI/ACE inhibitors followed by beta blocker, SGL2 inhibitors, and MRA. So this is the approach in reduced ejection fraction. Whereas it is always seen that in order for the strategies to facilitate implementation for guideline-directed medical therapy for heart failure, which is obvious because most of the time the patient presents to the emergency with heart failure, they need treatment before ascertaining all the other aspects, like whether it is reduced ejection fraction or preserved ejection fraction, by doing a proper echo. But so we have to start all the 4 classes of medication and diagnosis, and in hospital initiation for hospitalized patients, performance improvement systems which have been highlighted in some of those trials. Multidisciplinary heart failure disease management programs are very important, and navigators or pharmacists to guide the goal directed the treatment. So this requires a team approach, and telehealth programs have also been found to be helpful in such situations. So the management approach in heart failure with reduced ejection fraction is the foundational quadruple therapy. So quadruple means because there are 4 classes of drugs which are used one after another, and within 3 to 4 weeks, all 4 need to be used in any particular patient. The first is the ARNI or the ACE inhibitors or the ARB. The second group is that of beta blocker. The third group is mineralocorticoid receptor antagonist, and the fourth group is the SGLT2 inhibitors. In addition to them, to these 4 quadruple therapy, they may also require loop diuretics for congestion, ivabradine if the heart rate is more than 70, then CRT or ICD for ejection fraction less than 35% if symptomatic despite optimal therapy, and also they needed to be considered for heart transplant or LVAD in advanced refractory cases. So starting beta blockers during acute decompensation can worsen heart failure. So beta blockers should be only started when the patient has become euvolemic. So if you look into the parameter wise, we find that ejection fraction is more than 50 in HFpEF, less than 40 in HFrEF. LV geometry shows concentric hypertrophy in HFpEF, dilated ventricle in HFrEF. Primary problem is of diastolic relaxation in HFpEF and pump failure in the other. Gallop, which is heard, is S4 commonly in HFpEF, commonly S3 in HFrEF. The BNP levels are often normal or mildly raised in HFpEF, but they are raised markedly in HFrEF. Best outcomes are seen in HFpEF with BP control, comorbidity management, and SGL2 inhibitors. In contrast, the best outcomes are achieved in HFrEF with quadruple therapy along with device therapy. So the common patient is that early hypertensive female for HFpEF and younger post-TBI male for HFrEF as per our case. So there are evidences that there are limitations in the evidences for patients with HFrEF and advanced CKD. So if a reduced ejection fraction is also having a CKD, then it is probably a bit challenging for the clinician to give the best possible treatment. because whenever there is HFrEF with advanced CAD, there is concern for adverse events, limited understanding of proteinuria, underrepresentation in clinical trials. So we are not sure that whether we are picking up from the literature is actually valuable or not. Lack of standardized outcomes, competing event rates, and of course, inadequate evidence for heart failure therapy. If we have to approach, therefore, we have to approach in a stepwise manner. So let us first go to HFrEF and see what is the stepwise approach. The first step in HFrEF is of acute assessment. So along with acute assessment, there has to stabilize the airway breathing circulation. If there is congestion, one needs to give IV loop diuretics, either furosemide or torsemide. Avoid immediate beta blocker initiation if in acute decompensation phase, and also check blood pressure, creatinine, or potassium, and assess the perfusion. So after we go for a quick acute assessment, the step 2 is to initiate the foundational quadruple therapy, that is the GDMT, and this should start as early as hemodynamically safe. All four should be initiated within 1 to 4 weeks if it is possible. So the first in the sequence is ARNI or ACE inhibitors or angiotensin receptor blocker. The drug class can be either sacubitril valsartan, which is preferred, or any of the others. And the target is to reduce mortality and reduce admissions. The second choice is, or the second drug is the beta blocker. The drug class can be carvedilol, metoprolol, succinate, bisoprolol, etc. And they require that patient must be euvolemic first. Only then it is possible to use. The third drug is SGL2 inhibitor. So either dapagliflozin or empagliflozin, they are cause benefit independent of glucose, and they are very safe and good drugs. The fourth choice is the mineralocorticoid receptor antagonists like spironolactone or eplerenone. So the target, whatever we do, the target they should avoid. The target is avoided if the potassium is more than 5 or there is severe CKD. Next is the step 3. Step 3 is to symptom directed add-ons. So based upon the situation, we will have to consider add-ons, like if the heart rate is more than 70, along with sinus rhythm, we add ivabradine. Particularly if there is persistent congestion, we add thiazide or switch from torsemide to ultrafiltration. For persistent hypertension, we can add ACI or angiotensin receptor blockers or sacubitril valsartan optimization or hydralazine plus citrate. And in presence of CKD albuminuria, we need to ensure SGLTI as also considered for ACE inhibitors and angiotensin receptor blocker optimization. In the step 4, we have to consider device therapy, because after equal to or more than 3 months of optimized GDMT and ejection fraction, if it is less than 35%, then one has to think about device therapy. But that indication would be specific, like for ventricular arrhythmia prevention, ICD is good enough. For QRS more than equal to 150 milliseconds and presence of LBBB, then CRRT can be done. And when both criteria are met, that is, there is both ventricular arrhythmia as well as supraventricular, both are present, then one can go for a dual thing, device like both the CRRT and D. In step 5 is advanced HF referral, heart failure referral. It is indicated when patients remains NYHA 3 to 4 despite maximum therapy. So in that case, we have to consider either assist device, heart transplant, or we have to go for palliative care or home inotropes if patient is not a suitable candidate for transplant. Now I am coming to stepwise approach in HFpEF. The first step is to again identify the phenotype, the possible domains which are driving the HFpEF. So if you look into the phenotypes, hypertensive along with hypertensive of the left ventricle along with stiffness, indicators are LVH and high SVP. The second phenotype may be tachycardia or AF, and also these patients can be obesity or they have metabolic issues and they can have high output failure. So indicators are LVH and high SBP, elevated heart rate and atrial fibrillation. The BMI is also high, the insulin resistance, anemia and thyroid disease, they can also be indicated. The step 2 is the foundational therapy. So evidence is weaker versus HFrEF, but mortality or opposite symptoms benefit is also proven. So the class is SG, that is sodium glucose transport LT2. This is the benefit is that only one class consistently reducing hospitalizations. In addition, diuretics can also give symptomatic relief, but should be used cautiously, particularly in preload sensitive patients. The step 3 is comorbidity target treatment like hypertension control, heart rate, obesity, diabetes, sleep apnea, coronary artery disease, etc. So in all of these, it is important to ensure that there is no time is lost for the management of the heart failure. The step 4 is new or emerging therapies, which includes drugs like finerenone, then versigouat, omecamtiv mecarbil, etc. So the diabetic CKD phenotypes will benefit intermediate improvement and should be used selectively. So every 8 to 12 weeks after therapy can change, and then we have to take for step 5 is for follow-up and monitoring. So in step 5, we have to follow the potassium and renal monitoring, particularly when ACE inhibitors and mineralocorticoid receptor antagonists are used. NYHA class plus 6-minute walk test is also an important part of your follow-up and monitoring, and the BNP trend should be monitored as well as the echo. Thank you very much.